I'm Dr. Mohamed Alfy. I am one of the team members of Heartbeat Clinic, which is the team of electrophysiologists with the leading of Prof. Mervat Abul Maati, Prof. Rania Samir, and Prof. John Kamil, and the young consultants, me, Dr. Musallami, and our colleagues, Dr. Ahmed Al-Rasasi and Dr. Omar Nada. And I'm now going to start my presentation. It's about conquering the bundle of Kent. And we will having the cases of the last week, which is done by the team in El Fayoum and in Shifa Hospital. This is Louis Wolf, John Parkinson, and Paul D. White, and they started digging in the electrophysiology, working as an electrophysiologist. It has to be in a team. You cannot work by your own because changing hands is crucial in the case, and thinking differently is a very important thing inside the cath lab doing an electrophysiological procedure. This is a bundle of Kent, and this is the ECG characterization of the Wolf Parkinson. And now we are going to start with the tips. Tip number 1, it's a case-based tips. The patient demographics is a female, 30 years old, with normal echo characterizations and complaining of dizziness and palpitation. And this was her resting ECG.
Hello.
Hello? Okay, this is the resting ECG of the patient. And this is resting ECG during the EP procedure, in the beginning of the EP procedure. Actually, it was a very simple case, but it has...
Tell us where the pathway is from the resting ECG.
Yeah, from the resting ECG, we can see that the delta wave is positive in lead 1 on our left side, is positive in lead 1, and the delta wave is negative in lead 2 and lead 3. And on the beside lead 3 is lead AVF. It's totally negative in the inferior leads. And if we go to the chest leads, we can see that the transition is subtle between the V1 and V2. So from the resting ECG, we can see that it's a right post-receptal accessory pathway. Actually, it was a very easy case to ablate. We didn't have a long time to map. That was 12 lead in the beginning of the study.
Alfy, مش هقاطعك بس لو رجعنا if we went back to the ECG, there is an important point to differentiate between the endocardial post-receptal and the epicardial, or that the one you ablate from the coronary sinus. If you look at lead 2, the initial part of the delta, I think the initial 0.04 millisecond of the QRS in lead 2 with the initial part of the delta, if it's positive, like here in lead 2, so it means that you're not going to ablate it from the coronary sinus and it's not epicardial. But if it's totally negative in lead 2, this means that probably you're going to ablate it from within the coronary sinus and it's an epicardial, or there is epicardial connection of post-receptal accessory pathway. This is something I wanted to mention. Thank you, Dr. Alfy. You can continue.
Actually, Prof. Rania, it is a very important point. This is a very important tip. Because a lot of septal pathways, we have to go inside the coronary sinus and it is epicardially located. But this one was actually very easy, and it has a little tip to talk about. And this is...
Show us where you ablated it.
Okay, Prof. Mervat, this is the intracardiac tracing for the site of ablation. And we can
fluoroscopy. Tell the people where you went inside. show us this first and then show us the signal.
Yeah,
So
actually,
you expected post-receptal accessory pathway, and then you directed your catheter. Did you use regular catheter or irrigated tip catheter? Give them some information.
Yes, the tip in this case that we have to use an irrigated tip catheter, because post-receptor region, sometimes when you use a regular 4 millimeter catheter, the temperature rises and the watt decreases. And actually, you can face that the accessory pathway disappears, and after a few minutes, it comes back. If you keep ablating with a regular 4 millimeter catheter, you can face a recurrence problem after the patient come outside the cath lab. So the tip in this case that you have to use an irrigated tip catheter in this region. And actually, we used the Columbus irrigation pump in this case, and the case went successful, and that was 12-lead ECG post-ablation.
We want to see the successful ablation site.
Okay, that was a successful ablation site, Prof. Mervet. Yes. This was on a 100 millisecond speed, and if we can zoom on the successful ablation point, we can see that the AV was very short on the ablation catheter, and the delta wave, the V was preceding the delta by 43.
Okay, I think the second beat is better because the second beat is showing the accessory pathway. At the second beat, Alfy, there is an accessory pathway potential. With your cursor, show the people. Yes, okay. I can see that this is a very good site. The second beat shows the accessory pathway potential. The accessory pathway potential to delta is more than 40 milliseconds. So this seems a good site. In accessory pathway, do you map thoroughly or you go ablation immediately? What do you do?
Actually, this patient, Prof. Mervet, was complaining of pre-excited atrial fibrillation, but she lost her tachycardia ECG. One of the consultants, this patient was done in Al Haya Hospital in El Fayoum, which is a city in the south of Cairo. She lost her tachycardia ECG. So we didn't do aggressive maneuver to induce the tachycardia, but we mapped the accessory pathway, and we were lucky that we got this signal, and we ablated the accessory pathway, and it was successful ablation. It was a quick case, and the tip in this case was to use an irrigated tip catheter because of the trabeculations in this area.
Very good, Alfy. Go to the next case.
Okay. Yeah, this is a second case. The patient demographics is a 46-year-old male, and he has normal echo and recurrent attack of palpitations, and was a 12-lead resting ECG. I'm sorry that we didn't have the tachycardia ECG because they take this tachycardia ECG in.
No problem with the missed information.
If you
from this ECG, please.
I can't hear you well, Prof. Mervet.
Make localization of the accessory pathway.
Yeah. Actually, the truth is, when I have seen this ECG, I said that in the chest leads, I have seen that the transition was a late transition. That was, I have told my colleagues, but there was a surprise in the case.
The limb lead, you have to tell us that this is right until system.
Yeah, it was the delta wave was positive in lead 1, and it was positive in the inferior leads. So it was for me, it was a right-sided accessory pathway, and in the chest leads, I have seen that the transition of the delta wave was late transition. So I postulated that it was a right lateral accessory pathway or right anterior accessory pathway.
So from this ECG, I would like to tell the attendees, look at V1. If you have QS pattern in V1 and transition at V2 or V3, this is right anteroseptal, of course, with the positive delta in 2, 3, and AVF. If you see a small R in V1, you are lucky that you can go away from the his bundle region to the anterior part. Here we can see that Alfy noticed that the transition of the R is at V4, so he had some breathing, that it is not at the his. Was it like this, Alfy? What?
Yeah.
What happened?
And this is a 12 lead in the start. Actually, Prof. Mervat, this when we introduced the coronary sinus and the his catheter and the ablation catheter, and the tachycardia was induced with a right bundle branch aberrancy. It was an orthodromic tachycardia with a right branch block. And
okay, for the audience, yeah. Go back. This is the 12 lead ECG of the tachycardia. Show us. The accessory pathway is on the right side, and the
actually that was the tachycardia with it was an orthodromic tachycardia with a right bundle branch block. And while we mapped, we found that the accessory pathway was a parahesian accessory pathway, and we did a subclavian approach, but actually we didn't get. I cannot actually get the annulus by the subclavian approach, and I mapped from the inferior vena cava. And when I touched the his region, the accessory pathway disappeared.
Oh, so this is trauma.
This is bad.
when I tried Profrania to ablate, I had block, but it was a transient block.
Okay, very good.
And I decreased the watt to 25 watts, and I tried to ablate. The accessory pathway recurred, but during the study inside the cath lab, I said that I will stop, and I will refer this patient to my professors, Prof. Rania, Prof. Mervat, to do a cryo ablation or whatever they see it's appropriate for the patient. But in the post-CAS, I did an ECG. It was without pre-excitation with right bundle branch block. If you want to, professors, to comment on this.
This is very good illustrative case, really, really, Alfy. And it looks like it's a parahesian. We usually الcommon thing اللي حصل معاك إن هو you can when you map sometimes you pump it without يعني من غير ما تقصد. You bump it and it disappears, and you have to wait till it comes back, so it makes your life miserable. Yes. You tried your best from the subclavian. Sometimes you can ablate it. Dr. Mervat طبعا, she is the best and she has the most experience in ablating such accessory pathway, and we will benefit from her expertise. She taught me a lot, and I ablated a lot of antroceptal under her supervision when I was your age. But it's very tricky. ربنا يخليك يا دكتورة ميرفت. لا كبرنا خلاص. But it's tricky.
Regarding this case, this is a very serious case. He is a 53-year-old man with this accessory pathway, which is in very close to the his. Sometimes, if you go from the subclavian, use non-irrigated catheter. Use the biosense catheter. It's a low profile. You can move it up and down, and you can map with this catheter. And get good contact to this anteroceptor region. You can go as you did, Alfy, with a low watt and increase the watt, and you watch for any AV block. You know what happened? You are very close to the compact AV node. This is why you had like a Wenckebach block, and the accessory pathway also was blocked. These anteroceptal accessory pathways are very, very weak. They are subendocardial, and they are very fragile. Don't be astonished if the patient comes back with the accessory pathway again.
Yeah, actually, Prof. Mervat, we told the patient that if the accessory pathway came back, we are going to refer you to our professors, and we can do cryo, or they can do the same radio frequency.
Yeah, the cryo freeze.
Dr. Mohamed, I have a comment, please. I will present a case. دكتور عارفي ازي اخبار حضرتك ازي اخباركم
الحمد لله.
I will present a case next cardio Alex I did 10 years ago with Dr. Amir Abdul Wahab. A case like this. Every time we start ablation, after 2 or 3 seconds, heavy block from the right side. So we went transseptal from the left side to map the accessory pathway, but also we had heavy block and the accessory pathway continued. So we finally ablated it from the non-coronary cusp of the aorta, and it came very easily. Just after 5 seconds, it disappeared totally and didn't recur again. No heart block.
Yes, this is another option. You can map from the non-coronary cusp, very close to the HIS. But take care, in heavy block can occur also from that side. Don't be
That's
astonished.
There's a high incidence of AV block from non-coronary cusp. It's not a safe site also.
Okay, Alfy. اتفضلي يا رنا.
I had a little bit of comments about this case because it's a very important case and we can face it every day. So we have to know what to do. If you're going to go from the femoral approach, it's better to go with a long sheath. A deflectable or non-deflectable to fix your catheter. You have to start with a non-irrigated catheter and non-irrigated tip catheter, and you have to start with low energy and watch not and be careful not to bump the accessory pathway because it's very easy. Like Professor Mervat said, it's a sub-endocardial. You can easily bump it, and it would be a nightmare because you have to wait till it comes back. Like you said, Alfy, if you cannot do it, if it's pure parahesian and you have to have an HIS on your catheter and the incidence of complete heart block is going to be high, you have to shift to cryo if you have cryos available. If not, if it's close to this but not true parahesian, you have to make sure that you're not having a HIS or a tiny HIS on your catheter, not a big HIS, in order not to increase the risk of accessory pathway. Of complete heart block. I have a question for Dr. Mervat. Such cases of anteroseptal accessory pathways, which approach is better for ablation, Dr. Mervat, from your expertise?
My best approach is the left subclavian vein from up from the beginning, because you can hook the catheter to the tricuspid annulus, and you can move it and you can stay away from the HIS as much as you can. So the best approach is from the left subclavian vein, but use اللي هي biosense catheter. It's a 7 French. Don't use the bigger catheter, the irrigated tip catheter.
Okay. When you ablate it from the left subclavian, do you put your catheter below the HIS recording or above the HIS catheter? Above. Like the right anterior position.
Yes, you have to do this. Sometimes you get more V than A, and if you see a tiny HIS, it's okay. Sometimes I map during the tachycardia because this makes it clear if you have HIS or no. Sometimes I have to pace the right atrium in order to see the HIS when the accessory pathway blocks, and then you can see if the HIS is there or not.
Yes, right. Thank you, Dr.
Okay, Alfy, thank you very much, Alfy.